Hello, this is Amanda Strickland doing my Episodic SOAP note video presentation for NP 702. This is the fall of 2016. I'm going to attempt to start my screen share now and start my PowerPoint. So like I was saying, I'm Amanda Strickland with Frontier Nursing University. This is for NP 702, Primary Care 1, fall of 2016. My patient was diagnosed with otitis externa. Chief complaint and HPI. The chief complaint, the inside of my ear is crusty and sore. HPI, the patient is a 27-year-old Caucasian female in a usual state of good health who presents today with right ear pain that began 3 days ago. The pain began gradually after swimming and has worsened in the past day with constant pain. Patient's complaining of crusting, draining, a fullness feeling, and itching that started today. Pain is described as throbbing and aggravated by trying to lay on the right side. A heating pad was attempted to alleviate the pain but was not successful. Nothing makes the pain better, there is no radiation, and no over-the-counter medications were attempted. The pain is rated as an 8 out of 10 in severity. The patient denies history of ear infection as an adult, but may have had one as a child. Patient denies fever, recent cold symptoms, hearing loss, dizziness, or headaches. The past medical history. The patient was diagnosed with asthma at 5 years old. She says that it was well controlled with an albuterol inhaler that she used PRN, but she has not had to use that in the past 10 years. The patient does have an allergy to latex, which causes a rash. The patient's current medication, she says she does keep an albuterol inhaler at home that she can use 2 puffs, Q4 to 6 hours, PRN shortness of breath or wheezing, but again, she has not used that since 2007. She does take oral contraceptives. She takes orthotricycline low, 1 pill every morning, and she last took it this morning. She denies any over-the-counter herbal or vitamin usage. She also denies any hospitalizations, injuries, or surgeries. As far as her immunizations go, she received the flu vaccine in 2015 and the tetanus vaccine in 2013. Family history. The patient's mother is age 60 with hypertension that is well controlled. The father is age 64 with diabetes and hypertension that's well controlled. She does have one older sister that's 34 that is alive and well without medical history. Her grandparents, none of them are alive, and she does not know the history of them. Social history, she lives in her apartment with her significant other and denies any alcohol or drug use. She works as a middle school math teacher. Review of system. General, the patient denies unexplained weight loss, fatigue, or fever. HEENT, she denies trauma, denies headache, denies vision changes, or eye drainage. She has a throbbing right ear pain times 3 days with a fullness feeling. She has right ear crusting and drainage with itching and swelling. Denies any hearing loss or changes. Denies cough, congestion, or runny nose. Denies painful or difficulty swallowing. Cardio, the patient denies chest pain or pressure. Denies dizziness, syncope, lower leg edema, or palpitations. Respiratory, the patient denies shortness of breath at rest or exertion, denies cough, air hunger, or wheezing. She was diagnosed with asthma as a child, but she has not had any symptoms in the last 10 years. GI, the patient denies abdominal pain, nausea, vomiting, or diarrhea. Denies bloating, indigestion, or constipation. No changes in bowel habits or appetite. Denies any red, black, or tarry stools. Denies history of GI disorders. GU, the patient denies difficulty or painful urination, denies nocturia or polyuria, denies vaginal pain, abnormal bleeding, or discharge. She is in a monogamous relationship and has been for the past 5 years and uses oral contraceptives. Her last missed period was 10/16/2016. Musculoskeletal, she denies any muscle pain, joint pain, or stiffness, and denies any limits in her range of motion. Continuing on with our review of systems. Neuro, the patient denies any numbness, tingling, or headaches. She denies any episodes of confusion or changes in level of functioning, and she denies any seizure or neuro disorders. Psych, the patient denies any previous psychosocial history. She reports an adequate support system, and she denies any current or previous suicidal thoughts or depression or anxiety. She also denies any drug use or alcohol abuse and denies any changes in her work or social functioning. Our physical exam. Vital signs are as follows. Blood pressure is 121/64, heart rate 74, respiration's 18, temps 980, oxygen saturation is 98%, height is 5'8", weight is 85 kilograms, and BMI is 28.4. The patient is sitting on the exam table, appears well-nourished, well-dressed, smiling, with no body odor and appropriate personal hygiene. HEENT, Perla is present, sclera is white, conjunctiva pink, edema and redness to right external auditory canal with scant white purulent discharge, tenderness and facial grimacing with tragus movement to right ear with edema and narrowed moist canal. No edema or redness noted to left external auditory canal. Bilateral tympanic membranes are pearly gray, non-bulging with positive light reflex and visible bony landmarks. No tenderness with palpation to mastoid bone. The neck is supple, no masses, no cervical adenopathy, no erythema, and no exudate noted to the oropharynx. Cardio. S1 and S2 heart sounds are present with a regular rate and rhythm. No gallops or murmurs. No edema. Cap refills less than 2 seconds. Respiratory. Respirations are even, unlabored, and relaxed. They are clear to auscultation with no wheezing or diminished breath sounds. Neuro. The patient is alert, oriented, answering questions appropriately. Speech and facial symmetry are normal, and the reflexes are 2+ throughout. GI. The bowel sounds are present times 4 quadrants. The abdomen is soft, non-tender, and non-distended, with no masses. Musculoskeletal. Range of motion is intact with a normal gait. Psych. Good judgment and reasoning were demonstrated throughout physical exam. Assessment. So our current diagnosis is going to be otitis externa. Some of our differential diagnoses are going to be a foreign body, chronic suppurative otitis media, acute otitis media, or cellulitis. So with our diagnosis of otitis externa, so after the history of present illness and physical exam, the patient's being diagnosed. The diagnosis of otitis externa, this is an inflammation and infection of the external auditory canal. This is usually acute, but can also be chronic, lasting 3 months. Chronic otitis externa is usually fungal or allergic in origin and generally occurs in patients with underlying skin disorders, allergies, or untreated acute otitis externa. The etiology, this can be when protective cerumen is removed with an increase in the external auditory canal pH that can usually be from excessive moisture, which causes an increase in bacterial and fungal growth. This can also be caused by an obstruction such as earwax that can lead to water retention or by trauma. Pathophysiology, this is a superficial infection of the external auditory canal. Trapped moisture or trauma can cause skin maceration, which causes an optimal area for bacterial growth. Some risk factors, these include swimming, which is one of the most common ones, and trauma to the external canal. This is usually from a Q-tip or a foreign object. Some of the risk factors can also be not drying the ear after water exposure, hearing aids, being diagnosed with diabetes, and warm and humid environments. The prevalence, according to the CDC, in 2007, 2.4 million people were diagnosed with otitis externa in the United States. 18.6% of these were ages 5 through 9, 15.8% were ages 10 through 14, with 53% being greater than 20 years old. According to the CDC, the diagnosis of acute otitis externa displayed a pronounced difference with seasons. The visits peaked in the summer, with 44% occurring during June through August, and reached their lowest points in the winter. The rates were kind of similar per region, but the annual rate of ambulatory care visits for acute otitis externa was highest in the South, with 9.1 per 1,000 population, and lowest in the West, with 4.3 per 1,000 population. Continuing on with our diagnosis assessment, the most common symptom of otitis externa is otalgia. The rapid onset of this ear pain in acute otitis externa is typically the reason patients seek medical care. This is the most common symptom. They can also have erythema, edema, and itching to the external auditory canal. They can also have purulent otorrhea and may have conductive hearing loss. The otorrhea can be characteristic of the kind of infection. With acute bacterial, you usually have scant white mucus that may be thick. With chronic bacterial, you have a bloody discharge if granulation tissue is present. With fungal, the discharge is typically fluffy white to off-white that may also be black, gray, bluish-green, or yellow in color. According to the clinical guidelines with the American Academy of Otolaryngology, the diagnosis of otitis externa can be made based on the history of present illness and the physical assessment alone. No further laboratory or diagnostic tests are needed. If the patient is having any neurological manifestations, such as fever, headache, nausea, vomiting, dizziness, then emergent referral to the emergency department may be needed and further diagnostic testing may be needed. This is why the physical assessment is so crucial to determining the correct diagnosis. Continue with our management plan. According to the American Academy of Otolaryngology, the APRN must first determine the diagnosis of otitis externa by ruling out other causes of possible otalgia. The part of the management plan and treatment, the APRN should also assess the severity of pain associated with otitis externa and treat appropriately with oral analgesics. Dynamed Plus suggests a strong recommendation for analgesic treatment, which can usually be achieved with oral acetaminophen or an NSAID for mild to moderate pain. Constant severe pain or procedure-related pain may require an opioid, such as Ultram or Tylenol with codeine. The addition of topical lidocaine to glycerol eardrops has been given a level 1 evidence and reduces symptoms in adults with bacterial otitis externa. For diffuse, uncomplicated acute otitis externa, antimicrobials should be prescribed, such as polymyxin, neomycin, or ciprofloxacin. Acidifying agents and steroid eardrops may be used as well. These eardrops are typically administered as 4 drops 4 times a day for a week in the affected ear. It is also important to prevent water contamination in the ear during therapy. The American Academy of Otolaryngology suggests cleaning the ear canal when necessary to improve penetration of ototopic medications. This is especially helpful when obstructing debris is present, such as desquaminated epithelial, cerium, and purulent discharge. This may be done by the APRN or may need referral to ENT. Irrigation should always be avoided in patients that are immunocompromised or have diabetes due to the increased risk of malignant otitis externa. When extreme edema is present to the external canal causing obstruction of the medication, then an earwick may need to be placed for facilitation of medication. Continue with our management plan of antimicrobial therapy. Cortisporin otic, which contains neomycin plus polymyxin B plus hydrocortisone, is considered the first-line therapy due to the efficacy and low cost. This is available in a solution or suspension. However, this medication does contain neomycin, which can never be used in patients with perforated tympanic membranes. Another treatment option is Cipro-HC otic, which contains ciprofloxacin and hydrocortisone. This is not available sterile and therefore should also not be used with tympanic membrane perforation. Another treatment option is Ciprodex, which contains ciprofloxacin and dexamethasone. This medication is sterile and can be used with a perforated tympanic membrane or in patients with tubes in their ears. If the tympanic membrane cannot be visualized due to canal edema, it is safest to use a medication that is safe for a perforated tympanic membrane. Treatment for fungal otitis externa includes acidifying drops 3 to 4 times a day daily for 5 to 7 days, or for patients with a more severe infection, may need to last up to 10 to 14 days. Systemic antimicrobials should not be used unless evidence of infection extends outside the ear canal or for complicated acute otitis externa. Patient education. In order for proper treatment and to prevent concurrent infections, patients must understand the causative factors as well as prevention methods like keeping the ear dry. This can be done by using earplugs, which is generally not recommended, or a cotton ball with petroleum jelly before showering or swimming. They can also use a hairdryer on the lowest heat setting to the external auditory canal after swimming or bathing. Patients should be told to keep the ear dry and to avoid any water sports for at least 7 to 10 days. Limit the use of earphones and hearing aids until after pain and discharge have cleared, and also perform regular cleaning on these earpieces or hearing aids. Patients should be educated and instructed on how to self-administer eardrops and to complete the medication therapy for as long as was prescribed to them. Although rare, patients should be informed of the possible side effects of antibiotic eardrops, including hives, swelling, rash, itching, trouble breathing, dizziness, palpitations, or chest pain. If patients experience these symptoms, they should immediately stop using the eardrops and seek medical attention for any medical emergencies, such as hives, swelling, shortness of breath, or chest pain. Some antibiotic eardrops, especially ones containing neomycin, can cause allergic skin reactions. Patients should be informed of the signs, such as a rash, itching, and worsening of the inflammation to the external ear canal. If these symptoms are experienced, the patient should immediately stop using the eardrops and notify their primary care provider. This is just a continuation of the plan. The diagnosis is otitis externa, and the ICD-10 code is H60. This is an example of a prescription. It has the patient's name, date of birth, and address, as well as today's date. The prescription is for the cortisporin otic solution containing the neomycin 3.5 milligrams, polymycin B-sulfate 10,000 units, and hydrocortisone 10 milligrams per ml. This is to be given 4 drops 4 times a day to the right ear for 7 days. Dispense 10 mLs with no refills. And then this Amanda Strickland, the student nurse practitioner signature, is on it. As far as referral goes, uncomplicated episodes of otitis externa can be typically managed just fine by the APRN. Patients should be referred to ENT when there is any evidence of systemic involvement, such as fever, headache, cranial nerve paralysis, vertigo, or sensorineural hearing loss. If there is no improvement after 24 to 48 hours of therapy, patients should also be referred. Complicated cases of otitis externa with significant cellulitis or chondritis or with any sign of infection of the contiguous bone should be referred to ENT. Complicated cases of otitis externa that warrant ear canal irrigation, especially in the immunocompromised or patients that are diabetic or with wick placement, may need to be referred to ENT. Health promotion and disease prevention. Health promotion and disease prevention for otitis externa is based on methods used to prevent an area for optimal bacterial growth. These include, but are not limited to, avoiding prolonged ear exposure to warm, humid conditions, keeping ears dry and drying ears after swimming, showering, or perspiration, removing obstructed cerumen, but not with anything that may cause trauma to the ear canal, such as Q-tips, treating ear infections aggressively, and treating skin irritations, such as eczema, before it reaches the external ear canal. Follow-up. If patients fail to respond to initial therapeutic options within 48 to 72 hours, they should be informed to return for an office visit so you can reassess the patient to confirm your diagnosis of acute otitis externa or to rule out any other causes or to refer. Follow-up is also suggested if symptoms fail to resolve completely within 2 weeks after starting treatment. If a wick is placed inside the ear, they can also schedule a return for a follow-up to have it removed. These are my references. And I thank you for watching. Thank you.